With my patients that have prostate cancer who wish to discuss the surgical options, I always discuss the three options. Number one, open surgery. Number two, keyhole laparoscopic surgery. And number three, keyhole robot-assisted surgery. Open surgery, in my view, used to be the gold standard. My fellowship was in prostate cancer and I performed an extensive number of these procedures. I presented this nationally and I had excellent outcomes. I was very happy with the outcomes and the results. So the operation is done with an incision, usually in the lower abdomen, between the umbilicus or belly button and the pubic bone. It usually takes about 2 to 2.5 hours. Patients are usually in hospital for 7 to 10 days, and recovery is variable, but usually 1 to 2 months, sometimes a bit longer. But there were some problems with open surgery. There was significant blood loss, which was often unpredictable. It was very hard to get access because the prostate's in a deep, inaccessible area. And it's sometimes difficult to do an accurate anastomosis or joint. Sometimes it's also hard to do a proper nerve-sparing procedure because of the blood loss that can occur. Because of the concerns, though, and the potential side effects, I then started offering laparoscopic surgery or keyhole laparoscopic surgery. And I was very fortunate to be personally trained by the pioneers in laparoscopy surgery in the world. These include Claude Abu, Bertrand Guilleneau, Professor Valencian, Indabir Gill and Chris Eden. I conducted a workshop in Australia and was one of the first surgeons in Australia to do this. With laparoscopy, what we do is we make small incisions in the abdomen, we insert instruments into the patient, and this is an example of a laparoscopic port that gets inserted, and that goes into the patient. And subsequently what we do is we put instruments through this, and the instruments, for example, a pair of scissors, go through the laparoscopic port and get inserted into the patient. We then can open and close these scissors and we move these instruments. There is gas pressure in the abdomen, which is higher than the vein pressure, so there's less bleeding, there's a more magnified view, and we can get access to a deep, inaccessible area. So although I was quite happy with the outcomes of laparoscopic surgery, it is quite difficult to do. It takes a substantial amount of time sometimes, and at the end of the procedure you're quite tired, and the most difficult part, the anastomosis or the joint, is very difficult to do because the instruments don't bend. And fortunately, had a robot donated or partly donated to us through the cardiothoracic department actually, and fortunately I was chosen to lead the robotic program and I pioneered the use of the robot in urology. Initially it was quite difficult to do and it took a substantial time period, but fortunately because I had had the experience with laparoscopic surgery, it was much easier for me and I had a very, very short learning curve. I believe the robot did lead to better outcomes, and hence a significant part of my practice now involves robotic prostatectomy, and this is really patient driven. So I offer my patients open, laparoscopic and robot assisted surgery. I describe the pros and cons of all these options to them and generally let them choose what they wish to do, but increasingly a very large percentage of patients end up choosing robot assisted surgery.